Hello, welcome everyone. I'm Captain David Wong. I'm a pediatrician and medical officer with the U.S. Department of Health and Human Services. We're really excited to be launching our inaugural bonus hack session today titled Telebehavioral Health and Integrated Primary Care and Safety Net Clinic Settings. And we're calling this a bonus hack because this session and potentially series of bonus hacks is an extension of the HHS telemedicine hack learning community, which started as a 10-week learning community, which started on July 22nd. And the goal is to accelerate telemedicine implementation for ambulatory providers over this 10-week period. And there are 3 more sessions left with the main telemedicine hack series. And if you're not familiar with it, you can Google it, and I hope you can join in the future sessions. This telemedicine hack community has been very vibrant and diverse. We've had average participation of between 1,500 and 2,000 folks on the telemedicine hack series. And through various emails and conversations, we found out that there were folks in the community who are interested in having additional learning opportunities on specific topics related to telemedicine. So we wanted to create these bonus hack opportunities, and this is the first one, to kind of engage and meet the needs of the community. And we hope that there'll be other bonus hack opportunities in the future and that you'll check in as well. And so with that context, this session, like the other telemedicine hack series, is based on peer-to-peer learning. So we'll have 2 case presenters like we typically do for our topical sessions with TM Hack. And the sessions will be recorded and archived. You can find them on Train. Give us a few days for that. We'll also plan to have the Q&A transcripts included as well to maximize learning. And with that, I wanted to hand it over to Dr. Jonathan Neufeld, who's with the Great Plains Telehealth Resource and Assistance Center, and he'll be hosting and moderating today's session. Thank you very much.
Great. Thank you, Dr. Wong. And thanks for the invitation to do this bonus hack on behavioral health. That's one of the questions that we in the TRCs get most often, and so it's really great to be able to provide some content and also hear some great stories, implementation stories from our case presenters today. Ray, go ahead and flip the slide to the next one. The Telehealth Resource Centers, I just wanted to do a quick shout out to this group. We're funded by HRSA, same organization that funds community health centers across the country and a lot of safety net healthcare. And our job as resource centers is to provide technical assistance, that is consultation, training, all sorts of resources around telehealth. So if you're in an organization trying to implement telehealth or sustain or develop or evaluate a telehealth program of some kind, please reach out to us. You can reach us all at telehealthresourcecenters.org. Almost everything that we do is free and a benefit to the folks to the general public and the folks that contact us. Next slide, Ray. Just a few tips for the webinar. Make sure that you're muted, and we will have time at the end for Q&A. I don't think we have a survey, post-webinar survey, but if there is one, then we want you to fill it out. We are recording this webinar, and it will be available both at the TRC channel and through your regular TM Hack channels. And the slides are going to be available as well through those same access points. So they're not available right now, but at the end of the session, then they will be. All right, we'll go ahead and jump in here. So I'm going to start with a little bit of a didactic on telebehavioral health. This is an overview. And the first thing that I want to say, first thing I want to do is just give you a quick look at the session. I will be doing this brief didactic, then Tearsanee Carlisle Davis from the University of Mississippi Medical Center will be talking about their implementation. Our 2 case sessions will come after the didactic. First Tearsanee Davis, and then Paola and Velázquez and Nick Carson from Cambridge Health Alliance will present their implementation of integrated telebehavioral health in their setting there. And then we'll have time, we should have time for about 15 minutes of discussion at the end. Buckle up, because this is going to fly by. As you know, in these sessions, it goes quickly. The one thing I wish we had was more time, and in thinking about doing some sort of a didactic for telebehavioral health, We are all just trying to figure out what are the very, very best, very tip-top kind of tips and summary information that we can give you. Recognize that we could go into a lot more depth. I'm going to give you some regulatory background and talk about some models of integrated telebehavioral health that we've observed in the community and in various settings. I'll give you a quick little rundown of clinical skills and procedural recommendations, actually I think in an opposite order there. And then each of the other story presenters will definitely have more in depth on each of those. So the first thing I wanted to point out is that and many of you on this webinar will recognize this, that telehealth is a lot of things to a lot of people. And if there's anything about definitions and kind of background that you need to know, it's that there has been a lot of telehealth going on over the years, a lot of a large variety, a lot of research. And it is really in the last 6 months that most of the country has been exposed to one particular model that prior to these 6 months was actually a very, very small sliver of the telehealth that was going on out there. And that's direct to consumer services in the patient's home. There have been a number of other types of models as well. So and I'm not going to go into all the others, but just recognize that we're talking about something that is a fairly small slice when we're talking direct to consumer, and a lot of other telehealth, and I think some of the programs that we're going to hear about today also take place within clinical settings as well. And you can virtualize multiple dimensions of the integrated behavioral health or of the entire healthcare encounter. And so there are lots of different models and ways of doing that. In the last 6 months, we've had a tremendous amount of regulatory flexibility given us by CMS and by most states. And so a lot of the things that we're doing today are made possible by that flexibility. And I think we all recognize that at some point, those flexibilities will change to more permanent policies. At least that's the hope or the plan at this point. What exactly those permanent policies are going to be, we don't know. We're all waiting to find out. Everybody's got ideas about that. But right now, there's flexibility from most of the payers. There's flexibility from from OCR on HIPAA and HIPAA enforcement for platforms. So you can use a lot of different types of platforms that aren't necessarily HIPAA compliant. And we have some flexibilities with regard to consent and releasing information. So, and there are we can go into greater depth on that too, but I'm just pointing out that we're in a period of flexibility right now, and that drives a lot of what's going on. Integrated telebehavioral health. There are multiple models and multiple theories, but a lot of it based on principles of collaborative care. If you're familiar with that, you're going to hear more detail, I'm sure, about the models driving the cases that are presented today. In practice, there's a lot of variation in sophistication, in model fidelity. There's just a lot of variation out there in the real world. For example, what we've seen is you get ranges from sort of psychotherapy clinic that's more or less co-located. You got a behavioral health provider of some kind who is available in the clinic, and sometimes they're just scheduling long-term psychotherapy hour-long sessions for in terminal kinds of lengths, and that sort of a model happens. Sometimes that's the only provider and the only style that is available, and that happens a lot. There are more structured models, what I've put in the middle, where you have sort of limited engagements, where you have structured handoffs, where you have planned evaluations of standard instruments. And these structured models tend to allow a lot more control, fidelity to models, and they tend to provide better evaluated outcomes too in the long run. But again, the amount of structure and the amount of sophistication varies quite a bit across the community. And then finally, there's a whole world of collaborative care, specifically collaborative care model that's as it's reimbursed and modeled by Medicare. Those are much less common because fewer Medicaid programs across the country actually pay for them, but they involve or they allow a lot more technical flexibility in terms of settings and channels to communicate. You can use text and phone and video and everything, and it's outside of Medicare's telemedicine structure per se. So there's a range of models and a range of ways of engaging patients. Handoffs are generally the pinch point, and so you'll see a lot of attention paid to how cases are referred and handed off in these kinds of models. One of the things we've seen as a huge plus for organizations that are successful is they learn how to engage the whole staff, the front desk especially, in technical assistance and other ways of smoothing the entry into the telebehavioral health encounter so that patients have fewer technical problems. And then they also find ways to get the staff to virtually communicate with each other, whether that's through a huddle kind of a model, or whether it's text messaging or messaging through the EMR or that sort of a thing. So the whole organization is engaged in a fully integrated model. I'm going to jump over quickly the quality measures. Well, I'll say just a little bit about quality measures. First of all, most of the time we're talking about quality measures for telehealth components of service that mirror in-person care. We're trying to do the same thing. We're trying to get the patient seen. We're trying to reduce a lab value or optimize a value of some kind. We're trying to hit the same targets, provide access. And so often the process and outcome measures for telebehavioral health or for telehealth generally mirror in-person care. For satisfaction and technical quality, which a lot of times people are trying to measure, we try and simplify those because you don't need a lot of dimensions. They tend to be correlated, and you're really just trying to drive technical issues down to zero, whatever it takes to do that. So, so that's just a quick look at quality. As far as procedures, considering the context and being prepared and structuring the encounter are the basic overarching ideas. You want to do some emergency preparation so that as part of early on in the session, you'll probably hear this from our presenters, you're trying to figure out, do I have the information to respond appropriately if something goes wrong? Now, emergencies are rare, of course. In behavioral health, we want to at least not be caught unaware about those. And in an emergency situation, we want to be sure that we're responding in such a way that we're driving the encounter toward a reasonable conclusion, and that would be handing off care to some local entity that can take care of it. Now, maybe that's the client's parent or emergency contact person, or maybe it's local EMS, police, fire, whatever. But at some point, you want to be able to end the encounter, the virtual encounter, and in your documentation mention that such and such a situation developed, the situation was resolved and ended with care being transferred to the local person, whoever that was. You don't want to just say, patient was choking, I couldn't help, so I logged off. I mean, that's not how we're going to end these sessions. So you want to be working toward an appropriate handoff at the end of the session. I also talk a lot in our trainings, we talk about scripts. I don't know if we're going to hear much about scripting, but it really helps structure an encounter. I know it can sound a little forced, but we're talking about an encounter that, first of all, in healthcare, we do a lot of repetition. We do a lot of double and triple checking. We do a lot of that, so it's not new. And secondly, we have to recognize that the in-person encounter involves a lot of stages and a lot of moving toward an encounter in a special place with a special person. And when we're seeing the patient at home, none of that happens. When we're seeing them virtually, sometimes there's a lead up to that encounter, sometimes not. And scripts help standardize the encounter and help structure it for the patient so that they're ready to engage. And now I'm just going to give you a few technology tips. You probably hear these all the time, but they keep coming up in our presentations and our trainings, and so I put them out there as valuable. There's no substitute for practice and getting comfortable, nor getting feedback. First thing to recognize when you're doing live video, at least, is that you're trying to emulate an in-person encounter through a window, across a table. And that's why we emphasize large screens put up at a proper height. Now, granted, you're going to use a tablet sometimes, or you can use a cell phone sometimes. Those are all possible. But think about looking through a window at somebody across a table as a way to structure the encounter. And it helps you think about where your screen ought to be and how you ought to look in that screen. Raising the image, aligning the screen with the top of your head so that you're looking into the screen, looking into the camera, looking mostly level and not down or off screen somewhere. You also want to place your image toward the top of the screen to fill it up, engage a good amount of your torso, because if you gesture at all like I do, it helps in building rapport. It helps you to show up as a more three-dimensional person in a two-dimensional space. The closer your eyes are to the camera, the more you give the impression of eye-to-eye contact. And that's a little trick that a lot of people who work virtually recognize. I just have a few examples here to show that. In this first picture on the left, this is obviously just a staged photo because the cameras and the eyes aren't even in the same place. In the middle section, in the middle picture there, you've got the camera looking down and the individual looking toward a face that's lower on the screen. There's a large image. The person is very close to the screen, so you've got a big angle between the camera's angle at the participant's face and then the gaze down to the other screen. In the final picture here, we actually have a little more distance between the patient and the screen. That helps reduce that angle. You have an image that's high up on the screen, close to the camera, and so that the angle between the camera looking at the participant and the participant looking back at the screen is a narrow angle. And that's going to increase the image, the impression of eye-to-eye contact, which is helpful in all kinds of care, but especially helpful in telebehavioral health. That is the end for me. Again, my contact information will be in the slides and you can access them that way. I'm going to turn it over to Tearsanee Carlisle Davis and let her tell us about their experience at University of Mississippi Medical Center.
I am coming. Hello. Let's see. I'm going to share my screen. That's not the screen I want to share. So, which I'm trying to see. Can you all see the screen? Okay.
Yep, looks great.
Okay. All right. So I am from the University of Mississippi Medical Center, Center for Telehealth. We are a comprehensive telehealth center. We are located in an academic medical center. So our medical center is the only academic medical center in the state and the only level 1 trauma center. We've been doing telemedicine now, we say officially, for about 17 years. But of course, we all know that everybody's been kind of dabbling in telehealth longer than we can say officially. I'm not going to waste a lot of time here because I do want to make sure we have time for questions. So our mission here, I told you about us being the only academic medical center, level 1 trauma center, for a reason. We kind of have the responsibility to care for the entire state, not just the patients who come here for their primary care or for their regular health care. So that is one of the main reasons why we take telehealth so seriously, because not only do we have to think about those who come to us on a regular basis, but we have to think about our primary care providers, our rural providers, and our patients living in those rural communities who don't have the access that we often take for granted. And we also train the healthcare professionals that will go out and work in these areas. Specifically today, I'm here to talk about what we call our telemental health. It's called so many different things: telepsychiatry, telemental health, telebehavioral health, all the same thing in general. But we offer general and specialized psychiatric services via telehealth in a variety of settings. And this slide is not meant to be elementary, but it is to just kind of show you the different areas in which we can practice, the different things we can do, you know, inpatient, scheduled or unscheduled. We can do mental health evaluations. We're about to start doing some work with the Justice Court, you know, how long they have to wait on evaluations before people can, you know, stand trial. We're working in schools already, universities, prisons, you know, you name it. We can do it because there definitely is a need for more mental health services. So, but particularly I'm going to talk about mental health and primary care and talk to you about our model here. So we know that people with mental and substance use disorders may die decades earlier than the average person for various reasons. We know that untreated and preventable chronic illnesses like hypertension and such are aggravated by substance use or other mental issues. Barriers to primary care, coupled with challenges navigating our healthcare system, have been a major obstacle to care. So you put on top of that, them having issues getting to mental health care, that adds another layer of problems for them. Excuse me with these slides. I don't know, I'm having trouble with them. But anyway, so I'm going to move into a case study just to kind of bring it home for everyone. And I'll tell you a little bit about what we do in particular. So just think about rural Mississippi. Think about this patient who is living in a town of about 1,200 people, a 42-year-old African-American female. She's a single parent, unemployed, no car. She is active in her church, so that is her community, that's her family. She's dealing with fatigue, loss of interest in activities. She does have a family history of mental illness. She's the mother of a 10-year-old African-American male. He's having some issues at school. He is a great athlete, but his grades are poor. He's becoming more difficult to manage at home, and the counselor has called the mother. So we can imagine that this mom is feeling overwhelmed. Not only is she dealing with her own issues, but she's also dealing with some issues that her son may be having. Now, there are some things that we need to consider with this mother. We first need to consider her culture. So she's African-American, and we do know that there are some issues of distrust in the healthcare system among the African-American community, particularly as it relates to mental health. Also, we need to think about her resources. Remember, she's a single parent, so she does not have lots of resources. Transportation, she's in a small town. And then we mentioned trust already as far as the healthcare system goes. And I just thought this image, as I was looking at images, this kind of summed it up for me as I was painting the picture to give you a visual of what we're dealing with. So I kind of thought about our model, and I see it as a solution. Of course, it does not fix everyone's issue, but in this case, I think it's a good solution. What we do is we partner with the local primary care clinics to provide mental health services remotely. We literally reach out to these primary care clinics. We assess the areas, do needs assessments, and say, how far away is the closest mental health provider? How easy is it for them to get an appointment? Because we do find that sometimes they have the region health centers that are close, but still that does not mean that the people have access. So the appointments may still be 3 months out. That's not going to help someone who has needs that need to be met sooner than that. And so we partner with these primary care clinics and say, do you feel like your patient's needs are being met in a timely manner? And we, based on what the feedback that they give us, we work out an agreement where we provide the mental health services via telehealth in their clinics. So it has a lot of value, brings a lot of value, because the patient presents to their own clinic for their mental health services. The primary care provider is then now a part of the mental health care team. So it's not the traditional way, the old way, where you say, oh, this person needs a mental health evaluation, and we, do the referral, we send the referral out, you wait so long to get the appointment, then that patient has to then travel somewhere else for that visit. And oftentimes the PCP may not know what happened, to that patient. Did they ever show up? Oftentimes, I know when I was in primary care practice, I didn't know whether the patient didn't go or did go until they showed up for their follow-up with me. One of the other advantages to doing this is when that patient presents to their primary care clinic, no one knows that it's a mental health visit but them and their providers. That kind of removes the stigma of mental health, and promotes that patient actually showing up for their visits. Because we do know that in the mental health world, there is a very high no-show rate. So let's think about the benefits of us doing this this way through telehealth. One, she trusts her PCP. The PCP already has that relationship. I know that when I was in primary care practice, I would often have to convince my patients that a mental health evaluation or just talking to somebody was something that they really needed. I could really see how if this were available to me at that time, that I would have been much more successful if I were able to tell them, I'm going to be here with you and you're going to be able to come here and see that provider. The PCP is going to be involved. Think about safety. Think about, the PCP just knowing the medications that the patient is on, being able to provide reinforcement of the education that has been provided by that mental health provider. I already mentioned, no one is knowing she's seeking, the mental health care, no additional stressors, such as transportation. Am I going to be able to make it to my appointments on time? Also, that primary care provider knowing what's going on with her and her son. So being able to do a family assessment without her having to travel to one place and her son having to go to another place. Timely access. Our clinics, the way that we do our model is they contract for a certain amount of time, but when they contract for that amount of time, it's understood that as their need grows, they can get more time. So that's kind of, it's understood that we know that they're going to eventually need more time. And then also accessible follow-up. But in the event that they can't get in with our mental health provider, quickly, that PCP knows what's going on with that patient and will be able to meet their needs at that time. How often have we had a patient with anxiety that comes in and says, oh, I need such and such medication, but the primary care provider does not know the treatment plan and doesn't feel comfortable refilling that medication or making adjustments to that medication. Those instances would be rare in a case where the primary care provider is a part of this integrated care. And so I mentioned some of these things already, about the African American community. I just mentioned, I picked this group just as an example, but we know that this is the case for everybody. Mental health is needed for everybody. We know that we all have our thoughts and our views, but I really believe that integrating mental health into primary care is what we need to move toward. We need to stop thinking about it as something separate. Health is health, and mental health is a part of our overall well-being. Primary care settings have become the gateway, to behavioral health. We go, we take care of our blood pressure, we take care of diabetes, these are the places where these people are going to present. We have got to be more diligent about recognizing when our patients may need to be assessed for behavioral issues. But then we've got to know what to do after that. We've got to have an avenue for them to get the care that they need. And we found a way to do that using telehealth in the primary care setting without putting an additional burden on the patient and the primary care provider. Thank you.
That's fantastic. Thank you, Tearsanee. And Paola Velázquez and Nick Carson are going to take over for Cambridge Health Alliance, and then we'll have some time for discussion. Thanks a lot, folks.
All right, can you hear me? And you can see the slides, right?
Yep, looks good.
Great. Okay, thank you, Jonathan and David, for organizing, and thank you, Carson, also for connecting us. It's great to be a part of this session today. So my name is Paola Peynetti Velázquez. I am a Senior Performance Improvement Advisor in the Quality and Safety Department at the Cambridge Health Alliance. And with me is Dr. Nicholas Carson. He's the Medical Director of the Child and Adolescent Outpatient Psychiatry Services at CHA. So the goal today is to walk you through how we use lean and performance improvement methods to quickly design, implement, and scale up a telepsychiatry workflow in our health system during the COVID-19 pandemic. I will introduce you to CHA and also our project, and then Nick can walk you through the takeaways, which include lessons learned, recommendations, and next steps. So at CHA, we provide essential services to a culturally and linguistically diverse population that faces common barriers to care. The psychiatry department is the largest specialty service and encompasses programs across the whole continuum of care, from primary care, behavioral health integration, that was just talked about, to inpatient services. And we have a very large outpatient service, which includes PCBHI, and also a lot of clinics across our 5 cities of our 8-city catchment area. We have more than 220 providers. This includes both staff clinicians and trainees. And each year we complete around 100,000 outpatient visits. So it's a pretty large service. It's also important to mention at this point that we do have a centralized performance improvement team. So we are part of the quality and safety department. Having a centralized PI team helps have standard workflows with all the service lines. And also before COVID, we did not have any telehealth at all for any service line. So now we have telehealth across the different outpatient service lines, and we also use it, Jonathan was mentioning other uses for inpatient ED evaluations. We're starting to do that. But right now the focus of today is just to talk about outpatient. And for you to get an idea of how we were hit by the pandemic, we've hospitalized almost 1,000 suspected or confirmed cases up to today. And we've tested over 50,000 members of the community and also patients. I do want to mention that the work that we're presenting today has already been published in the New England Journal of Medicine Catalyst Journal, and is available as all their COVID materials to the public at no charge. So we encourage you to download it, read it, share it with your teams, and especially if you are interested in the figures that we're going to present and all the details within them, that may be a good resource for your hospital systems. So the vision for our project was to create access to safe and quality mental health care via telehealth. This meant that we needed to create a seamless workflow to continue seeing patients, ideally through video, while maintaining quality, ensuring patients, staff, and providers could adhere to social distancing and stay home, but continue their care. And as you can see, there were a lot of departments involved, and we're going to walk you through who was involved and also the timeline in the next few slides. I know this is a little overwhelming, but we want to show you the timeline of our project. So we did a lot of things in these 5 days. On, towards Thursday, the Incident Command Center of the organization asked all the service lines to design workflows for them to continue seeing their patients remotely during the pandemic, because we did not want to continue scheduling in-person visits for obvious reasons. And so on Friday, we defined the vision for telepsychiatry, and we spent the whole weekend pretty much designing an IT and operational workflow, developing the training materials for staff, scheduling staff and providers, engaging with the interpreter services, and then designing the communication plan for the patients and the families to know how to engage with the technology that we were designing. So by Monday, we were training providers via a Google Meet. And then by Tuesday, we were already scheduling the appointments that we began on Wednesday. So it was really fast, and that comes with its challenges, but everything was very urgent during the pandemic. And I think that everybody really came together that weekend to make it happen. So this slide includes the departments that were a part of the project. As you can see, we have grouped these departments in 3 groups: the core team, the subject matter experts, and the end users. Obviously, the end users are super important. And the end users, we're just talking about the staff, but obviously the other end users are the patients. Since this table only quantifies the staff, that's why the end users here are the managers, the providers, and the scheduling staff. For the core team, we had the clinical leadership of the psychiatry department, and also me and my colleagues in the performance improvement team. And then in subject matter experts, I already mentioned, we had the interpreter services, the marketing department, information technology, and more performance improvement, but geared towards training. So This table is for you to get an idea of exactly how much work is required if you're trying to do that in your own system. So this is a fishbone diagram. For our project, how we usually use the lean tools is that we explore exactly all the inefficiencies in the process. So we talk to providers, we talk to schedulers, and then we look at the technology, and then we map it all out in this fishbone diagram. 3 of the points that are highlighted that we chose to tackle, but we tackled more than those 3, but those are some examples, are an education plan for the patients, addressing language barriers to make sure we could include the interpreters through video interpreting and not only phone interpreting, because obviously video interpreting provides better care, and also dangers with the technology. So one example was the danger of joining the incorrect visit. That was a big concern that we had, and that was possible with the technology that we were using. The technology that we're using, by the way, was Google, because that is the platform that we have at CHA for other work, and we use Google Meet in particular. So the process in Lean for moving from the inefficiencies to the solutions is called the impact effort matrix. And it has one matrix, one axis is the impact and one other axis is the effort. And so the matrix has these 4 quadrants where we map out all the solutions that everybody had and then decide what we're going to do, what is worth doing, what is not worth doing, what is going to get us some buy-in, what is an easy, low-hanging fruit, and then really what are the sustainable strategies that we should pursue even if they take more effort because they're worth it. It's also important to identify what is not worth doing, even if it sounded like a good idea at the beginning. So that is this bucket of not worth doing at that point. Obviously, if you do another impact effort and you have more ideas, you can change where you place these solutions in the matrix. This is the workflow that we developed with the team. We really identified, like Jonathan said just now, that we need to prepare the schedulers and the patients just as much as we need to prepare the providers. So patients needed to know what technology to download, how to access it, if it's going to be in their language or not. We had instructions on the website in different languages with the screenshots of the of what the computer is going to look like when they access the visit. Schedulers asked the patients what they wanted, if they wanted video or phone, got their right information, documented it in Epic in a place that the provider could find it. So there was a lot of effort in these 2 phases, like phase 1, which is staff introduces video visit to patient, and phase 2, which is patient prepares for the video, in order to have a successful phase 3, which is the actual visit with the patient. And then to Jonathan's point about knowing exactly what to do with a patient that needs more in-person care or an emergency, the providers have the scripts during the visit, they have the right documentation that triggers them to do the consent correctly, and they also know exactly how to send the patient to the right emergency or urgent care or to call their crisis team. And this is just some example of the patient communication that we shared with patients and families so that they knew how to join the visit. And during the process, we had also a lot of improvement cycles. So each of these is a PDSA. PDSA is a quality improvement term for Plan, Do, Study, Act. And it means that you do something, you measure it quickly, you identify a better way to do it, then you tweak it, and then you do it again, measure it again. So all of these bullet points were iterations of the improvement cycles that we had to do very quickly, all the way up until in this diagram the end of June, but we're still working on it. And these 3 are examples of those improvements. Improving the documentation to make sure that we could bill for these appointments, improving the reports to make sure we knew what our volumes were, and then creating a technical support line for providers to call me in this case, and I would answer right away and be able to support them on the spot if they were stuck. So I know that was a lot of content, but now Nick is going to walk you through the takeaways.
Thank you, Paola. And thanks, Dr. Neufeld and Dr. Wong, for this opportunity. And thanks to Dr. Carlisle Davis for a very patient-centered presentation. It was wonderful. I will quickly take us through key takeaways and next steps. On our next slide, we have the takeaway that lean and systems thinking provide a a real pragmatic approach to maintaining continuity of care and achieving a rapid diffusion of innovation in a safety net health setting. So you'll see in the figure that we really maintained our outpatient volumes through late March to the beginning of June, largely by phone, but with a respectable increase in video visits through that period. The second takeaway is that telepsychiatry increases patient engagement. And through that, we had opportunities to redesign our mental health services and improve outcomes. This is an exciting slide to share because you can see that our no-show rate was decreased by half in the period after implementation of telemental health. And the attendance rates for video in particular were the best. So that gives you a nice justification for pushing for video visits in addition to the other aspects of improved quality that video offers. This is a quote from one of my child psychiatrists who wrote to us soon after the transition. She wrote, "Wow, I met the father for the first time. I observed them in their home setting. I coached the parents in the moment on how to behaviorally manage the siblings fighting as it was occurring. I explained autism spectrum disorder to the child himself and shared resources. This worked better than any of my hospital visits." So this is a particularly positive piece of feedback that demonstrates the value of a telemental health visit in giving a window on the home environment and on family interactions that can be so important in child mental health care. Our third takeaway is that an equity-based approach is fundamental to mitigating the risks of worsening health disparities. And here you have a heat map, which shows the relative adoption of video visits. And if you look in the bottom 3 rows, you'll see it was our addictions clinic, our geriatrics clinic, and our cultural linguistic teams that had the lowest uptake of video visits through mid-June. And you can imagine the many barriers to care in terms of digital literacy, access to digital technology, and access to instructions and supports in languages other than English that made the transition difficult in particular. So we're really focusing on how to support those services in particular. Our recommendations fall under those 3 themes as well. Lean can be a very powerful way to accelerate the diffusion of innovation. The workflows that you saw earlier were so essential. They really help teamwork across a variety of departments, both clinical and operations. They really helped with a collaborative process that was transparent, that we could share with clinicians quickly, that we could teach patients quickly using technology that we had at the time. We had to move really quickly, and we had the Google platform and used Google Meets. In terms of redesigning the health system, we recommend looking for evidence-based guidelines around delivery of telepsych. Dr. Neufeld's comments earlier give you a nice introduction to what type of approach in a video visit works the best. You have to use multimodal training tools. We use live video instruction like we're doing now that was recorded and shared later. We had a comprehensive slide deck, and we developed a dynamic frequently asked questions document that was very powerful in receiving feedback quickly and responding quickly with answers as best we could. You want to monitor clinical outcomes, patient-provider experience, cost effectiveness as best you can, and explore factors associated with patient engagement, which could be due to aspects of mental health illness and other social aspects around digital literacy, access to technology. These are relevant when you're striving for equity. You can measure access to digital technology through things like social determinants of health screening, which many health systems like ours are now required to do. Look for public-private partnerships to address gaps, such as community groups that might be able to donate devices to patients in need. Evaluate quality outcomes for phone versus video versus in-person visits, and prioritize access to interpreters and translation of materials through the EHR portal. We'll wrap up with our next steps. In terms of leveraging Lean, we're really moving towards a system-wide vision to align strategic priorities across departments as the uptake in video visits progresses at varying paces across our different departments. We've been fortunate to have a nice alignment of the EPIC electronic health record group with Google, so that now we can launch our video visits from within the electronic health record. We're thinking about the concept of a virtual waiting room and the benefits that can provide for administering questionnaires. And PI really allowed us to standardize workflows, and it will help us do that across all of our service lines. We're looking to further develop clinical guidelines for how to know who needs an in-person visit and who is okay to have virtual appointments, and a process for measuring clinical outcomes associated with phone and video visits. We want to deepen the reach of telehealth. It was very complicated just to get one person on video for a session. Imagine doing that with 8 individuals, or structuring a virtual partial program which provides programming for 4 or 5 hours per day. Finally, we're looking to mitigate disparities in access to technology that could be related to race, ethnicity, to language, to geography, to socioeconomic status. We've done some preliminary analyses here, and we think that disparities have been somewhat alleviated as you've seen an improvement in engagement, in ability for patients to meet their providers at home. We want to really support patients to enroll and use the EHR patient portal. There's a lot of opportunities for communicating with the front desk, for communicating with clinicians, and for hopefully administering documents back and forth over time, but you have to do it in a way that meets the needs of non-English speaking patients as well. And then finally, addressing technology gaps for providers and support staff. This is a tremendous transition in a very short amount of time, a huge ask across the system, and we still have much learning that we're doing together, and are looking forward to continuing that in the months ahead. Paola, you're muted.
I know. We just want to recognize everybody that supported this project, because obviously it's a team effort, and there are many, many individuals inside and outside of psychiatry that made this happen, including the executive leadership and their support. So if you have any questions, or if you are implementing telepsychiatry in your own organization and would like to talk to any of us, we are more than happy. I think we're going to share the slides anyways as part of this session, but we would be happy to speak with you about it. Thank you.
All right, thank you, Paola and Dr. Carson. That's fantastic work. A very rich set of slides. We have some time now for question and answer. If you are watching and you want to put your question into the Q&A box, I'm going to read a few questions here, and I know that Tearsanee is still around as well, and we will address as many of these as we can. So I'm going to start with in the Massachusetts presentation, where were these telepsych visits set up for only patients in the psychiatric service already, or are others needing assessment as well? How do you integrate with primary care?
I can take that question. Thank you for asking. Our psychiatric service is already connected with primary care, so we all share the same electronic health records, which helps integrate the care. The explanation that we gave today applies to evaluations for new patients that are just entering psychiatry. It also applies to the integrated behavioral health clinicians who sort of sit in primary care, and then it also applies to anybody that was already seeing a psychiatrist or a therapist and is just continuing their care. It also applies to somebody that is getting discharged from an inpatient unit and then needs to be seen right away.
Mm-hmm. Yeah. Dr. Carlisle Davis, thank you for your presentation. This was very informative. I'm reading a question for you here. Are there any plans to have shared appointments where the PCP and the mental health provider are both present for perhaps a visit? If I understand correctly, the current model would mean patients have a visit with the PCP and then come back to the clinic for a telemental health visit. Again, kind of that integration aspect there.
Yeah, right now, no. What we have found is that the PCPs in our models, the way that it is right now, is the PCPs want to be doing something else. So they want to go on and see another panel of patients. They don't want to be in there with the patients. They just want to make sure that their patients are getting the mental health care, that they need. They're not interested in being involved in the actual visit. Now, I do see some places where that could be very, beneficial for them, but in what we are doing right now, no.
Yeah, I know that question tends to come up from time to time, and it's sort of like this, I don't know, golden fleece that we all thought, yeah, the psychiatrist and the primary care doc are going to sit there in the room together, and it just rarely happens.
Yeah, and I can tell you that, like even when we looked at our Medicaid administrative code a few years ago, when we were looking at the telepresenter role, and Medicaid has this code over there, and they say, if you want to be paid for this time, they have to be in the room the entire time and all of this stuff. Nobody uses it because they don't want to be in the room the entire time. And so, they're just like, no, I could be seeing a patient down the hall rather than standing in here watching this professional do what they do. So, they just don't want to do it. But I could definitely see it in severe mental illness or, severe developmental situations where it's very important, like complex care cases where it would be beneficial for the primary care provider to be in there. But basic anxiety, depression, which are those things that we're seeing in primary care settings, they just want to make sure they're taken care of. They're not interested in using time when they can be taking care of another patient, another billable visit.
Yeah. And the record is integrated so that all providers can see the other.
They can see them. Yeah, they can see what's going on with the patient. And that's what I meant by that is, in the old way, we were dependent upon that mental health provider saying, oh, Dr. Carson sent me a patient, let me be nice and send him a record, of what I did for this patient so he knows what's going on, with that patient. Well, in this case, we're required to send them a record so that they can have a record of that telehealth visit and we have a record of that telehealth visit. So it's all there. The patient has consented because the patient is showing up at that clinic, for this care. So we're a team here. Everybody knows what's going on with this patient.
Yeah. So there's a question here about how does the PCP know that the patient is there for a mental health visit, or how does the team know that the patient is there for that? I imagine there's some signaling that goes along either through EMR or elsewhere. And is there some, I guess the concern here, it says, I envision a patient checking in and then going to a room, but never being seen by a provider. Doesn't that imply that it's a mental health visit? Like, let everybody know that it's a mental health visit. And I think the implication there is that, or the answer there is that the clinic staff, of course, have to manage those visits.
Oh, yeah.
They're aware of what's going on.
Yeah, the clinic staff knows, but so a good example of that would be like here, we have this place called Hines Behavioral Health, and there's a sign that you can see from the interstate that says Hines Behavioral Health across the front of it. So if you pull up, if you pull up in that parking lot and go in and sign in, everybody knows that they're there for a behavioral health visit. If I pull up to Jackson Primary Care Clinic, nobody knows why I'm there. I can be there for anything. I could be there for my wellness exam. Of course, the staff does know that I'm there for my mental health visit. If people were watching, yeah, they might figure it out. But what I mean by that is the stigma associated with me, the anxiety. I'm not sitting there thinking if I go there, everybody's gonna know, that I'm going there for a mental health issue. And yes, I agree. I see Donna, somebody made a comment about the PCP. It's not that they're not interested. You're exactly right, but they do have other stuff to do. That's exactly the point. They have a lot of stuff.
There's a question here about remote patient monitoring. I'm going to call it out just in case. I'm just wondering if any of you have looked into getting information from the patient's home and any kind of a device that might help. Now, the questioner says, for example, clinical grade wearables, biofeedback, et cetera, that we could utilize under the remote patient monitoring reimbursement codes. My sense is that that's still a ways off, certainly in the behavioral health space, possibly in chronic disease management. There's a lot more of that going on, or at least a little more of that. But I'm just I'll put it out there. Any of your clinics thinking along those lines at this point?
Only in a research context, I would say. We are doing some work in looking at how smartphone apps can send active surveys to patients about mental health issues, and also leverage the passive data that's collected around location and screen time. And you can derive a lot of insights there around sleep quality and things like that. But there's no direct clinical integration into the electronic health record. But it's been very hard to get vital signs. It's very hard. It's complicated to get labs. And when you're prescribing antipsychotics and stimulant medications, there's a metabolic monitoring piece to this. So I can imagine in the future when like your home scale will talk to an electronic health record, and that scares me a bit. But for the time being, we're having to find workarounds.
Yeah. There's another question here about integrating Epic and Google, and how does CHA protect the privacy of patients' information? And I think I want to put this into the context, a little larger context of informed consent in general, because I don't know if you find this, but we have found that patients tend to make a lot of assumptions or are curious from time to time about live video. Certainly the assumption that a live video encounter might be recorded, that's a very common assumption. I'm wondering what sorts of steps you all have taken with regard to informed consent and either monitoring that or obtaining that in the course of treatment.
I can jump in here. So that's a great question, and definitely one that we have been mapping out and discussing at length, especially concerning group visits, because those are, you can have 10 patients on there and you cannot really control what the patient is doing with their own computer. So that's also why it has taken us a while to really launch group visits in a way that we consider it safe for everyone involved. But I think that our IT security department has put in a lot of work with Google to really ensure that we can protect all the patient's information. And then there is also like an extra level of protection on the visits that are launched from Epic, which is why Nick was explaining that that's also the process that we're going to now. I think that there is a different consent that patients are now, reading and going through on my chart once they get into the virtual rooming. And I think that that consent may include language about how conducting a visit through video on the internet has some risks that, are part of any virtual interaction instead of in-person interaction. But obviously we're working really hard to mitigate those as much as we can. And like I said, that's why groups is tricky.
Mm-hmm. Yeah.
I think it's a great question too, very challenging. The integration of electronic signature platforms into email platforms and the electronic health record it's underway in our system, and I think it's an important next step for how to allow patients to sign documents and a way for a health system to share information and indicate that the patient has acknowledged the risks and benefits, or it's giving permission for you to speak with a teacher or another provider.
Mm-hmm. Yeah. I think that we're pushing the edges of a couple of different things. I mean, obviously, technology allows us to do a lot of things, and that we can't do in person, or that we can't do if we're restricted to in person. But there's always a payoff or a trade-off, and in healthcare we're always figuring out, is the risk of harm, justified by the potential benefit. And certainly, I think the whole experience with COVID-19, people still. I talked to researchers and others who are thinking, okay, how are we going to evaluate the effectiveness of telehealth during COVID-19? And the question that always pops into my mind is, what else were you going to do? I mean, how are you going to provide services at all if you can't figure out some way of doing it with, the highest level of security possible, but still in some sort of effective way, that when people are, stuck at home or can't travel for whatever reason. We're at the quarter hour, I guess, at our shut-off time. So I will take the opportunity to once again thank all of you on the panel. This has been fantastic, really, really rich presentations here with a lot of information. I want to thank all of you who've attended. If we didn't get to your question, we are going to distribute those around the panel. We'll take a shot at those in writing and get those out to you. As Dr. Wong and others have said, we'll have this available and through the normal channels. And actually, I'm going to turn it back to you, David, since you're still here, and let you talk us out here on this bonus hack. You're still muted, David.
Sorry about that. Thanks again, Jonathan, and all the presenters. That was a really amazing session, and I'm so glad so many of you were able to tune in. And as Jonathan said, you know, we're going to have these materials. Many of you asked about the recordings, the slides, the Q&A transcripts. They're all going to be on the train discussion board, where you can access the full TM Hack series as well. And stay tuned, because we are in discussions with other presenters and other experts in telehealth about other bonus hack topics. And so you'll start to be hearing more about those in the next coming weeks on the TM Hack main series. So again, thank you to everyone for your time and your attention. And with that, we can close today's session. So thank you very much.
Thank you very much.
Thanks all.
Bye-bye.